has pretty much nice amount of bone, but the other side, shown on the right side, we have a dehiscence defect on the buccal side. So soft tissue condition was good, and after raising the full thickness periosteal flap, we can see that I placed Dentium superline, 2 fixtures at each side. And as you can see here, on the right side, we don't have defect, but in order to have better contour, since this is a aesthetic site, we need to do some GBR for contour augmentation. But on the left side, we can see there is a defect, which was expected from the CBCT. So we need to cover labial defect on the left side. Okay, so for different reasons, but in order to have same quality of the result, I applied osteon 3 collagen, which is collagenated synthetic bone, and using this kind of bone graft, I was very happy to do some easier GBR, and I would expect to have higher positional stability. And after covering the resorbable membrane, I wrapped up my surgery by achieving primary closure. And as you can see, the healing was perfect, and the panoramic view shows the implant has been perfectly placed as I planned. And let's look at this CBCT taken immediately after the surgery. We can see that nicely positioned implants along with highly well positioned graft material on the, especially focusing on the coronal site. And a few months later, we delivered temporary bridge right after the second surgery. And this slide shows the state after the prosthetic delivery. And this is 1 year follow-up. You can see that the tissue looks fine. And we took another CBCT at 1.5 years after the surgery. We can see that the graft material that I placed has been well maintained at the site that I originally placed. So this means I didn't put any kinds of bone tacks or some kind of fixation material. Only what I did was just placing the collagenated bone, but they stayed so much well maintained at the site that I placed originally. So after 2.5 years, the patient recently came to my clinic for the follow-up, and I took this photo. Looks fine. So the case that I just showed you is one of the most frequently performed protocol, GBR, and many researchers told us that treatment success rate is over 90%. And this kind of predictability can be achieved by using this kind of biomaterials. And we use these kind of materials in order to keep the space that defect presents. And the reason we need to keep this space is in order to recruit the pristine osteogenic factors. So in the past, we used this kind of non-resorbable membranes because we thought keeping this defect need to be resulted from using some kind of everlasting materials. But thanks to the developments of many kinds of the materials, now we use these kind of biomaterials, which is resorbable type of collagen membrane and particulated bone substitute. We have so many benefits of using these two kinds of biomaterials, but we also have drawbacks. And one of the disadvantages, one of the drawbacks we have is the possibility of having apically migrated biomaterials right after the suturing. So we can refer this kind of apical migration to this kind of nature of gravity. And we also have this kind of gravity in the oral environment because once we place the implant and put some particles and then cover that with resorbable membrane, and then right after the suturing, this kind of apical migration occurs, and it ends up with like the state at the right side. We don't want to have these kind of migration after the surgery, because usually the defect we deal with is the Eason's defect, and this defect is mainly places at the coronal. So we really want to keep the particles at the coronal, but once we do this kind of suturing, we always have this kind of possibility of apical migration. And this phenomenon has been already proven by this wonderful in vitro study published by Zurich group. And in this study, they used pig jaw model, and they created a dehiscence defect and placed the implant. And they placed a few kinds of materials, block bone, particles covered by collagen membrane with bone tacks, and they compared the positional stability right after the suturing. So this is the results, and if I summarize the results, the summary is this: positional stability after the suturing coronal was hugely a lot more stable when we use block bone graft or we use particles with collagen membrane with bone tacks. But if we use just particles and just covering the particles with collagen membrane without any kinds of fixation, there will be a lot more chance of apical migration immediately after the suturing. So this is what we usually do. If we want to keep the particles at the site originally we placed for a long time, then we need to do something like this: pin fixation, bone tack fixation. Sometimes we need to fix the membrane with suturing. These kind of something to fix the particles needed during the surgery. But do we always fix the graft material? Do we always do have to do those kind of fixation? Well, I would say no, because it depends how the defect looks like. So let's take a look at these images. So on the left side, right side, we both have some kind of very looking similar dehiscence defect, but as you can see in detail, on the left side, the defect base looks like a sloped manner. But on the right side, we have a little bit more definite floor. So I would like to say on the left side we have here, it's like climbing a cliff. Let's say we are climbing a cliff, then we always have to keep the equipments for the safety. We need some ropes, we need some helmets sometimes, we need some specialized shoes. Without those kind of equipments, if I try to climb the cliff, everybody would say you're crazy. But let's take a look at this photo. On the left side, there is a pedestrian road. There is some kind of sidewalk for the pedestrians right aside the cliff. In this case, we don't need any kinds of equipment. We can just walk around. In this case, if I have some kind of fully equipped, situation, and I walk this sidewalk, people would say you're crazy. So in this case, if we have definite floor at the dehiscence defect, we can just omit. We can just skip using any kinds of fixation. So let's take a quick look at this case. We placed Dentium's aniline implant here, and we can see that the defect has the mesial and distal walls on the proximal, but the floor is pretty much shallow, or I would say we have no floor. In that case, we need to place some kind of bone tacks on the apical in order to prevent any kinds of apical migration we would have. So thanks to the using this kind of bone tacks, we can see that right after the surgery, right after the suturing, we can see that the particles has been perfectly localized at the site that I originally placed. And after 6 months, they stayed so much well maintained. But on the other hand, let's take a look at this case. We can see two defects on the buccal side, one dehiscence and the other one fenestration, but both of the defects are fully contained. So in this case, we placed Austin Zeno, which is particles, but I don't need any kinds of fixation. I just cover that with collagen membrane and then suture them. And as you can see here, the prosthesis looks good, and the tissue around the prosthesis, they are well maintained. And we took CBCT immediately after the surgery, and we can see that the graft materials has been well maintained immediately after the surgery. Has some kind of collagen portion which holds the particles as a one body. It's going to be a lot more easier to manipulate, and it would have additional support to the barrier membrane, eventually resulting in better positional stability of the graft material. So they made this kind of technique, which is called L technique. L technique. So this means we need to trim the collagenated bone into a L shape, which fits the dehiscence defect, and just plate over the dehiscence defect, just like we do during this kind of Tetris game, like this. And this idea has been well supported by these kinds of evidences, and we did randomized clinical trial co-working with Zurich Group, and we published these two papers. We used osteoin 3 and osteoin 3 collagen, and we found out that both of the particles and the collagenated bone, which were osteoin 3 and osteoin 3 collagen, both of them had wonderful results, similar performance in terms of having bone regeneration, but using collagenated type, which was osteoin 3 collagen, we could do easier and simpler GBR compared to placing the particles and covering with collagen membrane. And this L technique has been also supported by a recent long-term study, and this article concluded that L-shape augmentation seems to be a reliable technique when performing GBR, and clinical aesthetic outcomes were very stable and highly satisfied both in the clinicians and patient point of views. So they kindly make this illustration for the clinicians to guide how they did the GBR. So let's take a look at my cases. So this is the case that I did some kind of L-shaped technique, which I used collagenated bone from genus. And in this case, I needed to do some posterior side GBR along with implant placement. And as you can see here, after opening the flap, we can see the very narrow ridge, which means that I need to do some horizontal GBR along with simultaneous implant placement. I placed Dentium Superline 3 fixtures, and then I prepared osteogenesis collagen and just putting over the defect and covered with collagen membrane, and I didn't do any kinds of fixation, any kinds of suturing or bone tech placement, and I just did suture. And this is the panoramic view immediately after the surgery. And this is the CBCT taken immediately after the surgery. And you can see that the graft materials has been well positioned, well localized at the buccal side. Healing went well. And this is the photograph that I took before the second surgery, the re-entry surgery. And you can see that in order to, because I did GBR, horizontal GBR at the surgery day, I pulled up the flap in order to have primary closure, which ended up with like this situation, the coronal shifting of MGJ line. So I did second surgery along with apically positioned flap. So I raised partial thickness flap and then placed it apically, and then I applied healing abutments. And as you can see here at the stitch out after the second surgery, the MGJ line has been shifted to apical, having a well restored the vestibule depths like this. Okay, so this is the photo taken just before I referred the patient to the pros department. Still MGJ line, they are very way back, placed apical. And then this is the photo immediately after the delivery of the prosthesis. And the patient went to my clinic for 1 year follow-up. After the prosthesis delivery, it looks fine and very well maintained tissue that you can see here. And I would like to show some recent cases. So in these cases, I used to use Austin xenocollagen, which is a xenograft just came out from the company in a collagenated type. And recently, I really love to use collagen graft, which is originally collagen matrix for the substitute of the autogenous soft tissue. But this can also have a functioning as a barrier membrane as well. So here we have this edentulous site, partially edentulous site, and you can see there is a horizontal ridge atrophy. But once I opened the flap and placed the implant, I realized that one of the implants, they don't need any kinds of bone graft. But the other one, we have decent defect, which means bone is pretty much fine than I, had concerned. But which means the horizontal atrophy that I saw before a flap opening, this might be due to the soft tissue atrophy, not the hard tissue atrophy. So what I did was I just placed a small amount of Austin xenocollagen on the buccal side, and then I just put collagen membrane, and then I applied collagen graft 2 as another barrier membrane in order to have a additional soft tissue augmentation. And then I do the suturing. This is the panoramic view immediately after the surgery, and as you can see here, the site has well-maintained graft material at the coronal. And this is the photograph taken at the suture removal day. And this is the photo taken before the second surgery, before the re-entry. As you can see here, because of the flap advancement that I try to do at the first stage of surgery, the MGJ line has been shifted to the coronal. So because of the same reason, I did APF and placed the flap apically and placed the healing abutments as well. And I did this second surgery along with APF 2 weeks ago, and a few days ago the patient came to do suture removal, and we can see that the MGJ line has been well shifted to the apical and the healing looks good. So I referred the patient to the prostate department for the prostate delivery, and now the progress is working on. So another case, here we have another horizontal ridge atrophy. So after placing the implant, I applied osteogenecollagen, and then I applied collagen graft 2 as a barrier membrane and just closed the flap. No fixation. And healing looks good. This time as well, I did apically positioned flap along with the re-entry surgery. So flaps positioned apically. I placed healing abutments, and this is 1 month after the APF. You can see that the vestibule depth has been perfectly restored. The MGJ line has been shifted successfully to the apical, and now the prosthetic work is on progress. Another recent case, this patient came to my clinic in order to place 2 implants, and one of them we removed with the adjacent tooth, and then at the same day we tried to place 2 implants like this, and you can see that there is a decent defect on the distal side, and the site in between the 2 implants we have a bit horizontal atrophy. So we placed osteogenecollagen to cover the decent defect and also to overcome the atrophy. And then we placed collagen membrane, no any kinds of fixation, and just did primary closure. And here we have the panoramic view immediately after the surgery. The implant placement looks good, and we can see some particles, the particles bound together by the collagenated, in a collagenated manner, in a collagenated bone. And you can see here the CBCT taken immediately after the surgery. We can see that graft materials has been well localized at the site that I originally placed. So this is a healing. Healing looks good. And after second stage of re-entry surgery, I tossed the patient to the prostate department. And after the delivery of the prosthesis, which was almost 1 year after the surgery, we took CBCT, and we can see that the graft materials still placed very well-maintained position at the site that I originally placed at the surgical day. And then we just delivered the prosthesis. Looks fine. We need to keep watching it. We need to do the follow-up right now. Okay, so I think it's time to wrap up my presentation. So firstly, we need to have the contained defect, which makes the surgery more predictable. So we need to do the implant placements in a more contained manner in order to make the defect in a more contained manner. And secondly, thank you. And secondly, bone graft should be applied within the bony housing. And lastly, not the least, collagenated bone graft would make the surgery easier. We don't need any kinds of fixation. We just place the collagenated bone, for example, like osteogenecollagen or osteogen 3 collagen, and then just cover it with collagen membrane and suture them. It would have a optimized results in terms of graft stability. Okay, this is all I have for you. And I would like to briefly promote this event. This event is prepared by Korean Academy of Periodontology, and we have so many well-known speakers, including Dr. Sungmin Chung of Dentium. So we have live surgery from Dentium as well. We also have, like I just mentioned, Dr. Sungmin Chung's lecture on day 3. So if you are interested, please register this event, and I would like to see many of you in South Korea from 23rd to 25th in October this year. And thank you very much for your attention. Okay, welcome back. I would, probably assume that you had wonderful break time for 10 minutes, and I also did. So we had some questions, and two of them we are going to share with you. The first one was, what was the key reason for choosing a lingualized incision and full thickness flap elevation? In this case, what was the most important point in your flap design? Thank you very much for your very nice question, because this is what I always think about before I do my incision. So I suppose what you mentioned, the case you mentioned was the first one. So I would like to share my case again. Can I see my presentation again? Thank you very much. So in this case, as you can see here, most of the case I used to make a lingualized or sometimes buccalized incision instead of just giving a mid-crestal incision, because it depends on the defect configuration. So in this case, we had buccal defect, labial defect. So I did lingualized incision. If the patient had lingual defect, then I would prefer to place a buccalized incision instead of lingualized or mid-crestal incision. This is because the histology that we have uh, during the surgery, at the situation of the surgery, even though we cannot see this kind of histologic image during the surgery, but we can assume the situation. Let's take a assumption that we're placing an implant at the early stage. Let's say we pull out the tooth and then we waited for 1 or 2 months and we're going to place early implantation along with GBR. And let's say we just made a mid-crestal incision on the right side, which has been fully healed, and we don't have a huge defect on the buccal side. It's fine. It's fine to make a mid-crestal incision. But on the left side, if we make a same incision just like on the right side, my blade that I placed through the mucosa, it will cut all the way down to the defect floor, and it would cut all the having the tissues having a very much highly potential regenerative sources. I'm going to cut all the blood vessels. I'm going to cut all the cells which are giving source of regeneration. I would also cut the oven bone. And this will make a bad healing after the surgery. So what I always think about is I really try to place my blade on the intact periosteum instead of cutting all the regenerating tissues. So this is what we used to see before the surgery. Then we always do the planning with these CTs, right? So if we see some kind of defect on the buccal, like the image shown on the left side, then instead of planning a mid-crestal incision, we need lingualized incision on the intact periosteum, which places more lingual side compared to the labial defect, buccal defect. But let's say we have a lingual defect, then it's the opposite. We need to make an incision on the buccal side in order to cut the intact periosteum instead of giving a not so good incision all the way through the regenerating tissues. But if we don't have any kinds of huge defect, then mid-crestal incision would also work good. And this is just for having a favorable reconnection of blood supply once we suture the flaps. So making an incision in terms of biology, it is cutting a blood supply. we need to cut the blood supply as little as possible, and then we need to reconnect them as much as possible in order to have blood supply reconnected. So that's why I made this kind of angularized incision. If the patient has buccalized the defect, then if the patient had lingual defect, then I would, do the buccalized incision instead. And if the patient had no defect and very well healed ridge, then I would just place mid-crescent incision. So in conclusion, it depends on the defect configuration. Okay, so can we move on to the next question? So second question was, what were your selection criteria for using osteogen 3 collagen with a collagen membrane for GBR? If you had to pick one factor that most affects outcomes in terms of graft volume, membrane stabilization, or tissue tension, soft tension control, which would be? Okay, so I assume the question deals with the criteria of choosing osteogen 3 collagen or osteogen xenocollagen. If I'm correct, if my assumption is correct, I would answer this question by, well, frankly speaking, I used to prefer using xenograft, compared to synthetic bone, but I choose osteogen 3 collagen sometimes because the patient's the preference. In Korea, some patients, I would say not just in Korea, some patients, they have concern of having a graft material which came from the animal. And in Korea, there are a lot of people who are concerned of having a graft material from other person, used to be allogenic. And as you may know, allogenic graft materials, they're from not just a person, they're from a dead person, right? So some patients who are very sensitive to those kind of issue, they are very afraid of having something from other creatures. So, I used to talk a lot before the surgery, and I figure out that this patient is some kind of sensitive in terms of those kind of issue. Then I just choose osteogen 3 collagen because it's from the factory. It's from a just calcium and phosphate, and it's going to be fine to those kind of patient. But if the patient don't have those kind of sensitive issue, then I would just choose osteogen collagen. So I hope my answer satisfied your wondering. But I would say the material may affect some kind of outcomes in terms of graft volume, membrane stabilization. But for me, osteogen 3 collagen and osteogen xenocollagen both are very nice materials to have this kind of optimized outcomes. So my selection criteria for whether I choose osteogen 3 collagen or osteogen xenocollagen, it highly depends on the patient's preference. Okay, so I think it's time to wrap up all this webinar today. So thank you very much for your watching. And next live surgery webinar will be on July 3rd, Friday, 2026 from 7 p.m. in Korean Standard Time. So please stay tuned and hope to see you, many of you, on next live surgery session. Thank you very much.